How long did you say you have to go on your heel?
Yeah, I always say first week, or from the time from the surgery till the first office visit, minimum, you're on your heel.
First week?
No forefoot weight bearing at all during that first, for me, I do surgery on Thursday morning typically, and I have you come in on Monday or Tuesday, so that 4 or 5 days there for sure. And then, you know, again, everybody's different, everyone's surgery goes a little bit differently. Some people have more than just a bunion done too, so these aren't blanket statements, okay? Some folks have a bunion and 1 or 2 or 3 hammer toes done, and that changes the game a little bit, you know? So I'm just speaking in generalities here, but first week in that time frame, you're on your heel, and then you're transitioning into a walking boot. I might still have you a little bit more towards your heel, or in most cases, I'll say, you know, about 25% weight bearing, where you can just sort of touch that forefoot down and get onto your opposite leg. So in other words, if I had done the surgery on the right foot, you know, you're starting out like
Dan,
this.
is that, not to interrupt, is that for like a minimally invasive bunion? Because usually we weight bear them.
Yeah, this is what I do.
Okay,
That's
okay.
that's a good point. Dr. Tomasi's in the back doing paperwork. But he,
Look at it.
so he may say something different. This is what I like, because I don't feel as comfortable with the post-op shoe, but I put that on first because that accommodates the bigger dressing and doesn't have the more rigid buckles and straps going over the surgery site. So I like, yeah, it's very accommodating. So I like that surgery shoe, but at the same time, I don't like you tromping around on that, in that surgical shoe for those first 4 or 5 days, maybe 7 days. I don't feel as comfortable in that as I do once you get this nice sturdy, big walking boot on. Big difference between this and that. Okay. So, all right. Let me run through the PowerPoint, since Leslie was so nice to put it together for us. And I also want you guys to take one of our freshly made pamphlets with you tonight before you leave. And they're over there. Okay. Leslie, so to advance on this,
Push the arrows.
just the arrows. That's right. Okay, so you may not be able to see this very well unless you're close, but tonight we're going to focus on bunions and hammer toes. But we do most of the things now that we've done traditional open, larger incisions, we now do through small incisions. That includes bone spurs at different areas of the foot, neuromas, those are pinched nerves in the forefoot, and other nerve entrapments, that's a nerve entrapped anywhere in the foot or ankle. We offload corns and calluses by either shaving bumps of bone or by putting surgical cuts in bone to move it around. Taylor's bunions, those are the smaller bunions on the outside of the foot, behind the baby toe. We do those minimally now. Heel spurs, plantar fasciitis, a little bit bigger incision, but still pretty small compared to some other surgeons. Diabetic ulcers are offloaded at times where we'll shave down bump of bone. There's an implant that we place in a joint in the hind foot that helps a flat foot raise up to an arch. And there's a few other techniques as well. So it's not just bunions and hammer toes, but for tonight, as you all know, we're focusing mostly on bunions, but maybe a hammer toe involved also. So I think we all know what a bunion is. I mean, a couple of you folks came to see me because of that reason. But just to make sure we're all on the same page, you have a large bump of bone that is right behind your big toe, and the big toe often causes the big toe to go over towards your second toe. Okay, so that's a regular bunion, and then a Taylor's bunion or a baby bunion. It's on the opposite side, and it's a bump of bone behind the fifth toe, baby toe, and the baby toe will go in towards the fourth toe in that case. But we're talking about, in large part with this tonight, the larger bunion. Hammer toe typically looks like this. Sometimes it can look like this, and we call that a claw toe. And sometimes the contracture can actually be more back here, and we'll release tendon back here through a small incision. And so I think we'll talk a little bit about hammer toe tonight, but I think mostly about bunion. So she had this gal has not yet had the left side done. She did have the right side done, so you can see how far over the great toe was, and it was oftentimes laying on top of the second toe. And now you can see there's actually a space between the big toe and the second toe. That's one of our goals of the procedure. Also, you can see that the large bump is now nothing more than a very mild contour.
Do you shave that off?
Sometimes, and Dr. Tomasi almost always shaves that bump, okay? I almost always now do not shave that bump. We both shift that bone over. So it depends on how you shift the bone over and the way you shift it over that determines if you feel comfortable doing the bump or not. Sometimes I'll shift the bone over by making a cut in the bone back here. That's what that incision's for, to make a cut in the bone. Sometimes I'll shift it over, we'll fixate it. I use a screw, and I think Dr. Tomasi is now using a screw, and sometimes a pin as well. So I'll do a screw and a pin. The screw will stay in, the pin comes out. We do that right in the office. It's pretty much pain-free most of the time. If you have a little bit of discomfort, it's just you feel pulling or tugging, but the pin comes out. So we shift the bone over. Sometimes after I fixate it, put the screw or the pin in, I'll then say, I want a little bit more correction, I'll shave the bump at that time. Dr. Tomasi, for the most part, he'll shave the bump and then make the bone cut and shift it over. Surgeon preference, that's all it is, and it depends on how far you want to shift it over. I tend to shift over farther than he does, so that's how I get away with not shaving a bump in most instances. And he tends to not shift over quite as far, and that's why he likes to shave the bump. So it just depends on different ways to skin a cat, so to speak.
And these incisions are so tiny that you're pressed to find them a year later.
And you can see here.
Traditional incisions are like this, and we make them like that. And it's not an exaggeration.
And you can see this is where her incisions were in this particular case. She had one there, that's where the bone cut was made. And she had one back here, that's where the screw was placed. So that's the extent of the incisions. One that's about 2, maybe 3 millimeters, and the second one, 2, maybe 3 millimeters. That's it.
I find it hard to think how you're gonna push that bone over without, actually shaving it down or cutting it or something.
Okay, again, we cut the bone.
In half.
Oh,
Yeah,
you cut
straight
the bone
across.
in half.
Yeah,
Oh.
Straight across.
So through that incision, an instrument goes in, and on live x-ray, we watch this instrument cut through the bone, okay? And then we manipulate the bone over, away from being like that, push it that way, and then I put a screw in to hold those back together again and correct the position.
So you actually know what you have to go through that healing process to have that bone heal again, and, yeah, so.
Yeah, oh yeah, it's still, hey, listen, this is still surgery. I don't want there to be any mistake about it. But there's a lot of things we avoid that we used to have to deal with when we did the larger open incisions. But you're still healing a cut bone, plain and simple. Okay. And I think this is, well, it's going to come up in here, but let's go over the verbiage here. So most often it's at the surgery center. Okay, we do not do office-based surgery yet. That's going to be, for us, it's going to be in the future. Plenty of podiatrists doing this in a surgery suite in their office. We do most of ours at the surgery center. Once in a while at the hospital, Dr. Wiley will sometimes do a bunion correction at Mill Creek Hospital. But for the most part, surgery center. And again, there's usually 3, maybe 4 small incisions. 1 or 2 for filing down the bump, and also to make the bone cut that we talked about, and then we reposition, and then I make one for screw placement. Any questions so far? All right. This was a foot that was prepped with the soap that we used before surgery. Okay, so and the lights hit it just right. So I know it looks very slippery and slimy. But you'll see this in our pamphlet too. But you can see the large bony bump here. You can also see the second toe over the first toe. She had 3 procedures done, and I beg you to find the incisions. They're very difficult to find, and this isn't that far out. Surgery was performed on 5/30, May 30th, and this was taken 2 months later, 8 weeks out, 7/29. And I'll point them out to you, but that was an incision for the hammer toe realignment. That was an incision to shave the bump down, and I know I brought her big toe over a little bit, and I can't even see that incision where I made a bone cut in the great toe to bring it over also away from the second toe. But you can see I was able to get rid of the bump. I was able to get the big toe in better alignment in this direction, and the second toe in better alignment and going down and away from the great toe. So now all her toes line up pretty well. So this is an example of a bunion and hammer toe. Correct.
Dr. Olson, do you like to make your big toes poker straight, or do you like to put them directing just the hair?
I like to have a little natural contour, because good luck getting a poker straight toe in a shoe. And also, there's the flip side of us correcting the bunion. Your great toe, there is one complication we always worry about. The great toe can actually drift towards the midline of the body, go too far this way. So I like this type of contour here. And a lot of ladies do not like, guys don't care as much, but a lot of ladies do not like a large space in between toes 1 and 2.
Can I ask a question?
Yeah.
You know, like when people get braces, they have to wear appliances and stuff. Does your foot go back and look like it used to? I mean, do you have to wear, like, sleep with slippers on, or sleep with?
That's probably gonna be the best question we're gonna have, no offense to everybody else, that's a great question. 2 things about that. One is all bunions can recur after surgery, okay? I like to put my patients into orthotics, okay? So that's a corrective device, is an orthotic. An orthotic is a shoe insert, okay? Dr. Wiley does a procedure called Lapiplasty. Now they're telling him that those will never recur and it's 100%. No, they never say that. But Lapiplasty, the early studies that we have show good promise in having near 0 recurrence rate. Am I fair in saying that?
That's correct.
Yes. So, and Dr. Wiley does a lot of the Lapiplasty. Has anyone heard of the Lapiplasty? Okay. You know, it's not in the world of minimal per se, but you are ambulating. It is in the world of quicker ambulation, just like our minimal bunion surgeries.
Great.
So you're faster on your feet with his Lapiplasty, and you're faster on your feet with our minimal. Remember, with his Lapiplasty, with our minimal bunion procedures, the bone still has to heal. Okay? This isn't laser magic. This isn't hocus pocus. This is still cutting, and this is, it's just doing it through very tiny incisions to help avoid the chance for infection, the large wounds popping open, to help avoid the large painful scar. And you're going to see a lot of those other complications that we have.
And another thing too is, even before and after the surgery, most people wear the wrong size shoes. So we'll all of us will tell our patients, go to Meekers, go late in the day when your foot is most swollen. And everybody goes, well, why would I go? Meekers is expensive. Sure it is, because they have the best quality shoes in town. They're the only shoe store left in Erie County that will measure your foot. I took a size 9 my whole adult life. I'm at a 10 now. Our foot gets bigger. The ligaments in our body weaken and the body expands. As much as I'd love to say I have a 29-inch waist at 64, I don't. But I used to. So after these procedures, if you stick yourself back in a shoe that's ill-fitting, your chances of reoccurrence
without arch support.
Yeah, are greater.
So Dr. Wiley's Lapiplasty procedure realigns the foot and takes away a biomechanical flaw on the inside. I like to realign the foot with the minimal procedure and take away the biomechanical flaw on the outside. So that's why I preach arch support big time. He probably still preaches arch support
Oh yeah, totally.
afterwards,
Absolutely.
but I think it's a must personally, whether it's from a good high arch shoe or adding arch with an orthotic device.
I think real quick, I think one of the things with minimal, even what I do too, but minimal especially is when you do a traditional bunion and you're opening up the tissue, just like if you were to do a knee, do an elbow, whatever, anywhere, we heal with scar tissue. We don't heal with those pretty planes of tissue that we were born with or that we currently have. When you do something, when we do minimal, we're avoiding those large incisions like he was talking about, but the biggest thing is you avoid copious amount of excess of scar tissue. So you can have the greatest bunion in the world and it can look perfect and it'll last you forever, but you may lose a good portion of your range of motion
Because of all the heavy scar
because of all the
tissue.
scar tissue, because you're going through those different layers. When you do the minimal, you circumvent all that. The little bit of scar tissue from a little cut basically is
Pinpoint
really
scar tissue.
you're right, exactly. So that's very important with minimal.
Great point. I want to add one thing to Dr. Tomasi's statement. If you're looking for sneakers, there is a second, in my opinion, there's a decent second option, and that's Achilles Running Store.
Yes,
because
yeah.
They measure you also.
Yep.
But he means in general, I mean, you're not gonna get a dress shoe at Achilles Running Store as far as I know, so. So you have two decent choices in that way. Okay, so some of you have already taken this next step. So that would be to get in here for an appointment and talk to us. Just because you think you want your bunion fixed, or just because you think you have a bunion, of course it has to be evaluated by one of us first. We need to talk in detail like we are tonight, so you're way ahead of the game anyway. But also, I want to stress this, I tend not to perform surgery on a bunion just because there's a bunion present. I will tell a patient, if that's not bothering you, let's not fix what's not broken. In other words, I like to do surgery on painful bunions, not for cosmetic reasons. So just because you have a bony prominence sticking out, if it's not bothering you, I'm gonna try and talk you out of surgery, or I'm gonna refuse to do it. And then a lot of folks will say, but I know it's gonna get worse because I see my mom's foot or my grandmother's foot. And I say, well, guess what? When it gets worse, we'll fix it. Yes, it's true, it might be a little more difficult to fix, but that's unlikely, down the road. That's unlikely. It should be most likely is gonna be just as fixable 10 years from now as it is now. So just because it's there, if it's not painful, I'm personally probably gonna talk you out of it and not do the surgery. But,
So you do that with knees too.
yeah, they do that with knees, and I mean.
They'll
that's what
tell
all
you,
the
let the knee
orthopedists-
get bad, and then we'll do
just
it.
because it looks bad on an x-ray, in that case. We'll always get x-rays, and we review the x-rays with our patients. The patients that have come in, we don't rush in and out. I mean, we talk you through, and show you exactly what's going on the x-rays. And not only just tell you, oh, there's your bunion, but, okay, I tend to tell you where we're gonna cut it, how we're gonna shift it over, this is what I want afterwards, and that kind of thing. And then, of course, you have to sign consent papers. We go over that at length because we want to make sure that you are fully aware of what you're getting yourself into, what to expect preoperatively, meaning, obviously before the surgery, because our pain protocol, with our medications that we use to try and avoid the heavy narcotics, that starts the day before for us. And that gives you, that helps tremendously. It just does. Are they getting are you gonna hand out versions of this or not? Okay. She'll give you a handout of this presentation, and on that handout, you'll see our pain protocol sheet. And we utilize what's called Lyrica, and it helps with, it dulls nerve pain, and Celebrex, which helps with anti-inflammation, so it's an anti-inflammatory. Some people can take Celebrex, and we alter that a little bit. If you're allergic to sulfa, we recommend you don't take the Celebrex, okay? I like to get blood work and EKG. I tend not to force someone to go see their family doctor too often. If someone has a cardiac history of any kind, you're not only getting a chest x-ray, you're not only getting an EKG, but you're also going to see your family doctor minimum, and maybe even a cardiologist. But in many cases, I like to get the EKG and the blood work just to be really safe. And the anesthesiologist doesn't know you from Adam in most cases. So they like to, that gives them a lot of information that they need to know how safely they're going to administer anesthesia, which is obviously very important. So that's why we tend to get these things. They're not always needed. Surgery centers have a guideline that we go by, and they tell us sometimes it's age specific, sometimes if you have a smoking history or not. So there's different factors that play in, but oftentimes you'll need at least a blood work and EKG, sometimes a chest x-ray, sometimes primary care physician seals.
If you're over 50, those are required.
Those are required.
In most institutions.
We always give, hopefully, too much information. I believe we give a lot of good information. So you should never be wanting for, okay, what's expected? What do I do? Not only do we verbalize it when we sit down and go over the surgery consents, but you have a lot of this information to take home with you. So we have handouts that, all the education you need, because all three of us want you to feel very prepared for not only your actual surgery day, but what's to be expected afterwards as well. And again, the day before, where you start taking those medications. And then once everything's understood by patient and us, then we'll go ahead and get the surgery date scheduled. Okay? Any questions before I go on to the next
What
slide?
surgery center do you go to?
I do a lot of my cases at Hammett Surgery Center, and I do a good portion at Village Surgery Center, and once in a while I go to St. Vincent Surgery Center. They're all good, okay, and they all have good anesthesia departments, anesthesiologists. That's what you want to know first and foremost, probably. They're the ones putting you to sleep and waking you up. They all have good accommodative staff. I really haven't had any complaints about the staff at any of those places. St. Vincent, for me, is just tougher to get scheduled. They have a more stringent process of getting patients on a schedule, so that's why I go there less than the other two places. I have a block time at Hammett Surgery Center, meaning I know exactly when I can get patients on, so that therefore I go there more often. Dr. Tomasi is exclusively at the Village Surgery Center. That's the one that's up on
Is that St.
Interchange.
Vincent?
St. Vincent is right across from St. Vincent Hospital.
What's the village?
Village is independent,
Oh, it's independent.
not affiliated with Hammett or Vincent, and it's right up on, near the Mill Creek Mall and Zook and Interchange Roads. Dr. Wiley is either Village,
Mill Creek.
Mill Creek or
Meadville.
Meadville. And
Mill
Dr.
Creek
Wiley,
Community?
Mill Creek Community is an option, yeah. Alright. So the good thing is we have an affiliation with not only all three large institutions in town, but also we have an office in Meadville. Dr. Wiley and Dr. Hess take care of Meadville for us. Alright. So this is the pain management protocol. This has made a world of difference for our patients in our practice. We love it because I used to write for at least 30 hydrocodone, Vicodin, or Norco, depending on what you've heard of before. They're all the same thing. Now I tend to write 20 at the most, sometimes 15 or 10, depending on the patient.
Now, do you start off with the Norcos for the first day or so?
Yeah, that's the reason I write it, because of
Okay,
that
now
first day or so.
Now, can you also write, like, if the person needs Zofran to go with Norco?
Yes, those are specific things, patient dependent. I very rarely do that, but I have. And it sounds like you're someone that would need something like that, or in your experience.
Was this pain
You'll be
good?
surprised at how taking that medication before the surgery, our patients are taking one or two of these narcotics, and that's pretty much it.
That's it. It's amazing.
But we would still accommodate you and write for this.
Yeah, every time I take,
Hey,
I
would you move
don't
over there,
try to
please, so
take
we don't have
that.
to keep turning around?
Because every time,
He's coming out of business for his chiropractic friend. That's what he's doing.
I get Norco and I just take one, 20 minutes later, I'm very ill.
Yeah.
Do you take it with food?
Yes,
Do you cut
and
the
I can't
tablet?
hold anything
Do you
down.
cut the tablet in half?
No, I've never
Cut
done
it in
that.
half. It's not uncommon that women have issues with narcotics, so we have you cut it in half.
No,
You
I
take a
usually-
half a tab
uh-huh.
every 3 or 4 hours. It's much easier on your tummy and on your nausea.
Yeah, the last surgery I got, they gave me the Norco and 8 milligrams of Zofran to take together.
Before I go into the next slide, does anyone want a cookie or there's diet iced tea back there?